Me too. I already.
Right, great. So we're going to transition now to this panel, continuing with the theme of a conversation and doing some cases. These cases are going to focus on improving the safety of transitions to OTPs between both ATS, CSS, and hospitals. This is just a brief outline. I'm going to go through introductions, and then we're going to go through some cases highlighting the transitions of care. And then at the end, have some summary slides related to successes and challenges related to this topic. So I want to thank the panelists. There's a lot of expertise both on the last panel as well as here. We truly have experts in the field, so I want to thank them. First up is Ari Kriegsman. He's the medical director of Carlson Recovery Center, an ATS facility in Springfield, and he's transitioning from 5 years as medical director of Mercy Hospital's Addiction Consult Service to the medical director of BHN Springfield OTP. Thank you. Julianne Elifson, did I say that right? Close, Elofson, sorry. Medical director of addiction medicine at Dimmick Center in Roxbury, ATS level of care, 2 CSS programs, an outpatient addiction clinic. She completed internal medicine and addiction medicine fellowship at MGH. Thank you. Next up is Marcy Lyon. She is the director for BHN's inpatient SUD programs in Greenfield. She has over 20 years of experience doing behavioral health. Thank you. And Jeff Baxter, Chief Medical Officer for Spectrum Health Systems. That includes ATS, 2 CSS, 2 OBAT offices, 15 OTPs, large correctional division providing MOUD throughout the Commonwealth's DOC facilities. And then myself, I'm the medical director of addiction medicine at South Shore Health, which includes a consult service, bridge program, OBAT, and SHORE program for pregnant and postpartum women. And I am the medical director for Spectrum Weymouth's OTP. And I have worked in several detox programs. So with that, it's not advancing the slides. Sorry about that. Oh, shoot.
Read the case and then I'll look.
Okay. Sorry about the technical difficulties. So we're working on getting it to show up on the screen, but the first case is a 35-year-old female who's on methadone maintenance, 80 milligrams at the OTP. She happens to be guest dosing at a clinic. She's currently actively using fentanyl, benzodiazepines, and cocaine. She goes to an ATS for stabilization on a Saturday. The ATS reduces her methadone dose to 40 milligrams on day 1 and 35 milligrams on day 2 until the methadone dose and status at the clinic can be confirmed. I highlight here as part of this case the nature of guest dosing and home clinic and sort of which does the ATS reach out to, who is responsible for the patient, who confirms the dose, and who sort of designates the patient as in good standing with the methadone clinic. So from there, the ATS team feels that methadone isn't effective, which I see and hear all the time, as the patient has ongoing fentanyl use and may be too risky to continue the higher dose of methadone because of using benzodiazepines. The patient is placed on the ATS protocol until the patient's good standing can be verified with the home OTP. 2 days into the ATS course, the methadone dose is 30 milligrams and the patient leaves AMA. I'm going to pause there. And I'm going to open it up to the panel, especially those who have worked in or work in ATS settings. I would invite you to tell us how you handle these cases and how we can improve the care of patients going from OTP to ATS. Going first.
I'll go. Okay.
So first I want to say this is basically every patient that we see in an ATS setting. And so it doesn't seem exceptional. The first thing that I think that we would do is I think we would focus on giving them the 40 in the day 1. Try to get the confirmation of the dose as soon as possible. We wouldn't make that drastic of an adjustment to their methadone dose. Rather, we would focus on safely either making a benzodiazepine plan with their prescriber if they are to have one, which not often that they do. And then figure out how we're gonna safely transition them to a benzodiazepine taper if necessary, if they don't have a prescriber to support that benzo script on the when they DC from ATS. And we would probably leave the dose. Here's the truth. We would increase the dose based on the symptoms of the patient at that time and how they were presenting, despite receiving confirmation all the time from their home clinic as to what their dose was or their good standing. Chances are they're not in good standing if they're in ATS. I mean, that's just the reality, what it looks like. And so, I don't know, most often, the patients that we see in ATS, they drive and decide our protocols. I mean, I don't want to take any credit from Dr. Poti, who's our medical director, but the patients dictate our care in the sense of how they're feeling and presenting. So that's kind of how we would do it.
Great.
Yeah, I mean, I just want to emphasize how challenging it can be to confirm methadone doses. I think it's really like the bane of our nurses' existence at ATS. Unfortunately, a lot of our patients arrive to ATS in like the mid-afternoon through the evening hours, and that's exactly when most methadone clinics are closed. So a lot of patients show up, already in acute withdrawal, and they are expecting to get their regular home dose. And it's unfortunate when we have to tell them, I'm sorry, we really have to wait to confirm your dose with your clinic in the morning when they open. But we do the same thing where we sort of place them on our standard methadone protocol, so we can at least give them, the 40 milligrams within that first 24 hours. And then hopefully the nurses can get in touch with the clinic in the morning. But even that is a challenge, even when the clinics are theoretically open. I think there's just short staffing on both ends. I mean, we're incredibly short staffed at ATS, and I know the OTP, nursing staff is also extremely short staffed. So to have two really, really busy nurses connect within limited hours when the clinic's open can be really challenging, especially if we don't have a relationship with the clinics and they're coming from other areas of the state. So it can be a challenge, especially on weekends and Sundays if some clinics are closed, and holidays too.
I'm also thinking about what does the patient look like on the second day when the dose is decreased. And yeah, you might not be able to verify that dose, but we can still think of an ATS as an induction center. So say that they're not on a methadone clinic, we can still go up. And so I think what we're not hearing, imagine if this person was on 80 milligrams and they got 40 and then 35, they probably look terrible. And so what are the communications in the clinic between nursing and medical staff? So the dose could be changed. And the way I look at it is if we can't confirm a dose, that's fine. We can still think of us as an induction and starting that. And then the conversation around, are they in good standing with the clinic or not? I mean, I think some of that's geographic. I guess if you're in a setting where there's no other OTPs around besides their own OTP, you might be in trouble from methadone perspective. But I think in many cases, there's multiple OTPs around. I know where I practice, we have like 3 or 4 around us. And so if they're not in good standing, but they need a life-saving medication, we can start it, find a different program for them. And then if for some reason we find out that we've inducted them because we weren't able to confirm a dose, you could always potentially backtrack and detox them, or if there was no methadone clinic anywhere around that they could go to. We also often flip people to Suboxone if that's sort of what makes sense given all the circumstances that they're in.
If I could just add, so there are a lot of gray hairs in this room, so not everybody's, some of it been in this field as long as I have. It wasn't that long ago that ATSs would actually turn away people who were already enrolled in methadone programs, right? And again, credit to our SODA's office, because that's not tolerated anymore. There was a time when methadone programs would not accept people who were started in inpatient settings or in ATS settings. And that also is no longer tolerated. But this is perhaps what was going on in this case, right? That I try to remind ATS providers, we use ATS as the higher level of care for people who are in outpatient treatment and aren't doing well. Mm-hmm. So if someone is on methadone treatment and they're struggling, we actually refer them into that system in order to help them stabilize. So reducing their dose is the exact opposite of what I'd like to see happen when they go into those settings.
Yeah, so that's all really well said. I guess I might just add, if we made an analogy to hypertension, if the patient goes into the hospital with hypertensive urgency, the hospitalist or whoever's managing that patient in an inpatient unit isn't confirming with the PCP before they give hydralazine or whatever it is to manage that patient's acute problem. This type of scenario happens every day. Raise your hand if you work at an ATS. Okay, so that's a pretty large number of people. Hopefully this case resonates with you. I think what we're looking to do is try to improve our communication between these levels of care and have a better communication between ATS staff, OTP staff, and care for the patient that's in front of you, as opposed to being maybe as hyper-focused on, are they in good standing? Having worked in ATS, I respect the fact that you have to make sure that they have somewhere to go when they're done. So I think we need to be realistic about that, but we also need to be sure that we're caring for the patient in front of us. This patient leaving AMA is a bad outcome.
I might just add too that like, so I think they got 3 days without a dose confirmation or a clinic confirmation, which that's never happened in our ATS, or I've never heard about that, but I imagine it might happen. There might be some clinics that are hard to get in touch with. That's really difficult to fathom. And I would just say, know your OTP folks and have somebody's cell phone numbers. Like I might not pick up the phone the first day, but I definitely would pick up the phone the second day and first or the third day. And so I think it's incumbent on all of us to get to know the folks in our community who we're working with.
I think that's right, but I would just add that this case was the patient went to ATS on a Saturday, presumably in the afternoon. Clinic is closed on Saturday. The clinic may be closed on Sunday. By the time Monday rolls around, it's sort of 2.5, 3 days into the ATS course. Hopefully we're moving towards sort of like a PMP for methadone, so people can check this stuff without having these externalities.
I still think I'd want to hear, as the medical director, I'd want to hear if 2.5, 3 days were going by without a dose confirmation, and that I would then reach out to one of my colleagues and on their cell phone on a weekend and say what their situation was.
Yeah. So part of the point of today is to get networking included in this. So that way, you know who your medical director is at the OTP and you can network with that person, get their cell phone number. I think too often we're working in silos.
Yeah, and I'll say like I started this job right out of fellowship, and I came from, very heavily resourced MDH, very well staffed. So it's kind of like going to the wild, wild west to go to a detox with no EMR. We're still on paper charts. There's not easy access to labs, no EKG machine. So I think it took me a while just to sort of tease apart the regulations around the ATS setting, because it is sort of like a vague gray area, especially if you're new to that world. It's not exactly inpatient like a hospital. It's not exactly outpatient. It's not really like an outpatient typical OTP where you're longitudinally following patients over time, but you do have an OTP license. So I think it is tricky to tease apart like what we can actually do. So definitely, as many memos as you can send out and trainings that you can do, I think that would be so helpful for ATS programs.
Does anyone want to comment about who is sort of responsible for managing the methadone when the patient's in the ATS unit?
So we, for better or for worse, take full responsibility for it, and it's like an inpatient hospital, right? So I'm not consulting with the outpatient people about this, but you get variable responses when you go to refer the patients back. So that's a problem. I think on the reciprocal side of that, I get a little frustrated when my OTP patients go into inpatient settings and I'm getting messages saying so-and-so called from this facility saying they can't increase the patient's dose without our permission. And I'm like, what are you waiting for? They're in your inpatient setting because they're unstable. Take care of business and tell me when you're done.
That's what I want. Yeah. You want to comment on that? Anyone else? No.
Yeah, I mean, I think it took us a long time to realize that, like me as a medical director, I did have the power to change patients' doses. I'm very happy, to have learned that, within the last year. So we have been, able to offer that, more flexibility to increase doses. And, for a while, we really thought that, even though we had an OTP license, given that we were in ATS setting, we really couldn't go above 30 milligrams for patients newly starting on methadone maintenance. So, since we learned that we really can be an induction center and did have that, that power to go above that, it's really been such a game changer for our patients, because that was such a common reason for premature discharge from the program. So we really have moved more toward like a faster paths induction approach, doing like a 40, 50, 60 titration. So that's been extremely helpful.
And we actually had a phone call yesterday morning, or a video Zoom, I guess. And I wish I would said I'd been doing this for a while, but I think it was put into place or motivated by this panel. But we finally had a call with our ATS providers and the medical directors of the 3 local OTPs, and just ran through a few cases and been like, hey, you know, similar cases we're running through right now, like this person's on 100 milligrams of methadone, they missed a week. How would you restart them? How would you feel comfortable with us restarting them? And sort of running through some cases, and like, are we all in the rough sort of ballpark? Like, this is what we would do. Is it okay with you if we do this and send them back to you? And anyway, it was great. And I think we're actually all pretty close. And I think that we attribute to Western Mass where we work in this great OTPs. But I also, you know, even if we disagreed, but I think getting a sense both of where people land with this and, you know, respecting each other's opinions, but also like, okay, that's who you are. That's your face. That's your cell phone. This is who I am. These are the great providers that we have. I think you get a level of trust and understand how people practice. And also then, okay, this makes you a little uncomfortable. Great. That's the one I'm going to reach out to you about. But you're cool with this? Super. So it's something that I hope will continue. And I think it worked really well.
That's well said, Ari. All right, let's move on to the second case. It's actually a great segue to the second case. 40-year-old gentleman with cocaine and benzodiazepine use on methadone maintenance, 140 milligrams, missed 6 days of dosing before going to the hospital. The hospital started on day 1, 20 milligrams. Did I do something bad? Day 2, 90 milligrams. Day 3, 100 milligrams. Day 4, 5, and 6, 120 milligrams. Day 7, 130. Day 8, 140. Plan was for DC from the hospital on day 9 to the OTP. So we're not going to light the room on fire, but we are going to discuss this case.
It's okay. We'll cut to the chase because Evan and I were. So Evan was very diplomatic when he answered the question about getting pushback, because he and I regularly go back and forth about some of these cases. But you know, the bottom line is I 100% appreciate what people are doing, like pushing the old envelope, because as you saw from Zoe's great summary, the old envelope is very old and hasn't been retested under new circumstances. So we welcome the opportunity to test these different settings. So what really helped with this case, like when I got this referral, I was like, no, we're not doing that. You went from 0 to 140. But then I was able to you know, go back and forth with Evan. He's like, well, what's not in the chart is that this patient was on 140 milligrams in the community until 5 days before coming. And I was like, oh, well, I wouldn't have restarted that guy at 20. I would have restarted that guy at 100 or 120, right? Had I known that. So the communication makes a big difference. Evan has mixed feelings about me having his cell phone and his email. But yeah, I think we're going to come to, you know, better understandings about how to best treat the patient, and more communication is better.
Anyone else on the panel want to comment about the case? I can go back.
Well, can I just, I'm sorry, and I promise I won't speak on the next case because I'm talking too much. But so I have a referral on my email today from another Boston hospital that has a pregnant woman that they've gone from 0 to 140 with 20 milligram a day increases. And they're like, okay, we're ready to send her out. And so again, I appreciate Evan's more nuanced presentation about what they're trying to do. Like, I don't feel like as an outpatient OTP provider, I can safely accept that patient. I'm not going to write an order for 140 milligrams a day for that patient. I'm not going to do it because that's so far outside of the range of what's accepted practice. And I'm not going to have nurses with eyes on that patient every day like you do in an inpatient setting. But, you know, when I get a referral that says, well, we've had this patient for 10 days and we've actually monitored them on a dose for 3 days, that makes me much more comfortable. I think that is the right sort of balance, right? Between having somebody in a higher level of care, getting them started with all kinds of safety mechanisms like ongoing monitoring, EKG monitoring, you know, sedation monitoring, right, where we're going to be able to accept those people into outpatient practice. And I do look forward to the opportunities to collaborate on further outcomes, because we certainly have had examples where people get discharged from inpatient settings on higher doses and they're sedated as hell, right? but do we get to get that feedback back to the people who started them? We don't, right? So we need better systems to really monitor the true longer term outcomes when people come out.
Yeah, if I can just add quickly, when I saw this titration, my main concern is about the rate of change and less so about the actual cumulative dose, which sometimes I think we get caught up on. I think I agree with what was said previously, that there is a comfort level in an inpatient setting, whether it be ATS or hospital, that does allow for rapid titrations, as was previously discussed. I also think that there are opportunities to do more rapid titrations in an outpatient setting, but not to the same extent or degree that you might in an inpatient setting. So I want to be clear. I think we could do better in both settings, but I don't think they're equal. And so I appreciate the opportunity to lead this panel because it is somewhat unusual for providers to work in inpatient and outpatient settings. And so I think it's a unique opportunity to hear that perspective.
Yeah, I mean, I think compared to like working inpatient at MGH, thinking about now my ATS setting, like I definitely wouldn't feel as comfortable, going up as quickly as we did at MGH. I think a lot of times we're really in the dark about patients' medical histories and medications, especially, at DMIC still being on paper charts. It's really hard to get information. A lot of times we're just relying on patient report, which we all know is not the most accurate. And a lot of times, understandably, patients will, not report their medical history just to get one of these life-saving beds when maybe they really are more appropriate for a level 4 detox. And a lot of times patients just don't have a great understanding of their medical problems, and their care has been fractured between multiple different healthcare systems. So, we had a patient last week who told us after 5 days of being there that he had chemo the next day. And why do you have chemo? And then he told us he had, active multiple myeloma, and, we had no idea, and we had not checked his labs or anything like that. So I think I do have concerns about just going up faster, just because I think we don't have a great understanding of their other problems going on. We also just don't have the same nursing and provider ratios that we did in the hospital. Like we have about 16 patients for one nurse. So they're super, super busy. We don't have 24/7 provider on site there. So I think we just wouldn't be prepared to respond if we did have adverse events.
Dr. Gale?
Thanks. I do want to say something about this case since I was involved in it. And I appreciate what you brought up, Jeff, about having that communication. Going back to that dosing, that titration. I mean, I really don't feel bad at all about the first 6 days, because that's getting back to what the person was on before, and really taking that approach that I talked about earlier, where inpatient hospital setting, lots of monitoring, we can get them back there quickly. I also think it's important to note for days 7 and 8, this is a patient who during those 2 days was titrated from 8 milligrams of Dilaudid every 4 hours down to 4 milligrams. So that's a dose decrease of 100 morphine milliequivalents. Now, I don't think we did a good job of putting that in our chart. And I think that comes back to, like, when we're talking about the communication, we want to think about the things that we're going to send over to OTPs that will help them understand, why are we making these changes right at the point of discharge? But I do think that's an important piece of context here that I was able to get through personal communication, and that could also be put in written communication.
Agreed.
So also, he was at a low dose because that's in the ED before he got to see us in the inpatient setting.
Their protocol is 20 milligrams. What was it? So yeah, I mean, that's why I started the takeaways with communication. I think it's really key. I think we can move on to the next case. So this case is related to pain and addiction. 50-year-old gentleman with severe opioid use disorder, benzo and meth use, on methadone maintenance for many years. This is a case that I cared for, actually. So this patient walked off the methadone clinic 13 months prior to what I'm about to tell you. He presented to a hospital with sepsis and multiple loci of infection, including spinal cord and discs. He had multiple surgical procedures for debridement, washout, source control, and had hardware. He was hospitalized for 5 months. Okay. Methadone was restarted in the hospital and titrated to 150 milligrams. The last surgical procedure was roughly 3 to 4 weeks prior to discharge. He was discharged on MS Contin and oxycodone and was a direct admit to OTP. He dosed for 7 days at the OTP and was AWOL for the next 8 days. During that AWOL period, he presented to the same hospital that started him on methadone, and he was there for 5 months, and no methadone was given. He left. He presented to another hospital. Again, no methadone was given. He re-presented to the methadone clinic using fentanyl, had scripts for MS Contin and oxycodone, and those scripts continued for about 6 months post-discharge. So I'm hopeful to just have a discussion here about pain and addiction and how hospitals and OTPs can communicate about these cases and sort of think about what is best practice for this complicated patient. I'm going to hand it over to the panel for their wisdom.
I might be the most hospital-based person, so I'll jump in. I think the first thing that comes to mind is I'm always like, no one's going to prescribe you the MS Contin oxycodone when you leave. I'm going to be as aggressive as I possibly can to treat your pain while you're in the hospital. We can't do that enough, I think. And it's at least in the hospital I've worked, that's been probably some of the most important work we've done. But I'm always usually thinking like, no one's going to give you any pain medicine when you go. Who's going to be your provider in the community? So usually I'm thinking about tapering everybody's opioids, or maybe they have a few days when they leave from the hospital, unless there's an agreeing provider, which there so few are these days. I don't know enough about this guy clinically to know where he stands physically and what the thinking was about why somebody really, continued them as Contin and the oxycodone, and then why someone continued it for 5 months afterwards. But I'd like to think that there was a good reason, and maybe there was severe illness, severe pain, obviously. I think one of the things just sort of thinking about clinically for me is I would probably be thinking about split dosing this guy with his methadone and trying to build that MS Contin into his methadone dose to simplify things. So just a little bit of my clinical piece, which would obviously then, if I was thinking about split dosing, would want to be in touch with the OTP. And I think you're going to need an OTP partner who would agree with that as an idea.
So, all right, I broke my promise. Just to sort of provide a different perspective. So if I look at this, so we have policies in our OTPs where anybody who's going to be on opiates for more than 30 days goes to medical provider review and gets very carefully reviewed for the safety and appropriateness of that treatment. Because let's not lose sight that this is an illness where people's judgment is impaired, and we've just come off the effects of 30 years of poor quality opiate prescribing. So you're not necessarily, one prescriber is not equal to another prescriber. So we are actively going to question whether or not those prescriptions are appropriate for someone with an opiate use disorder. And then if I have that conversation with the provider and they say, yeah, boy, this person really needs these opiate medications and I'm going to keep prescribing. I'm like, good, prescribe all of them. Why are you making this patient come to the OTP if you're comfortable and you're guaranteeing that this person is safe with supplies of opiate medication? Take over their pain management and manage it. So we at our programs lean towards no, you do not have multiple cooks in the opioid kitchen. Okay. If a person is safe to have pain management, like we absolutely support short-term trauma, post-op. We will go out of our way to support that patient. We do all kinds of surrogate applications, like you said. We do all kinds of things to make sure that patient's treatment is not interrupted and they get the pain treatment that they need for their acute condition. We are very skeptical of long-term co-occurring methadone treatment and opioid pain treatment, okay? Because if you can send a patient home with a prescription for opioids and you think that's safe, then you should be able to manage their pain comprehensively within your care center and not need us to be involved.
Just to clarify, do you mean, Jeff, that the PCP would be managing the methadone as well? Or?
I say, well, if methadone's the appropriate medication, then use it. If methadone's not the appropriate medication, transfer over to ones you're comfortable prescribing. It's really about the cooks in the kitchen, right? You don't need, It is not safe to have multiple people managing high-risk medications. Take control of it, manage the patient.
Yeah, I would point out also that I think from my perspective, I have the hindsight of knowing this patient, but I think the hospitalization was a missed opportunity. This patient was in an inpatient hospital for a very, very long time. And I agree with Ari that it would have been very appropriate to both split the dose. Look, we've done TID at times in the hospital and raise the methadone dose over time at a minimum, in my view, so the MS content was off prior to discharge. From my perspective, MS content methadone at discharge is a contraindication. This case was exceedingly difficult to manage in the outpatient setting. I think there were missed opportunities to continue methadone when he represented to the other hospitals, which made the representation of the representation a nightmare. Yeah, I'll stop there.
I mean, I think we just can't lose track that there's individuals and patients are all different. And there's going to be some patients who are on methadone who I think need opioid agonist treatment for pain. I don't know enough about what this person is at clinically, but there's people out there who need it. I personally believe that. And I think, I think there are some safeguards we can think about, like, sometimes if we're concerned about somebody's opioid use, but they have severe pain issues, and we can set up a VNA who can do a lockbox, or is there a reliable relative who can get involved? And there's a lot more footwork to do that. I mean, I think we're talking about sort of extreme cases in these cases, but I'd like to think that there's somebody out there or a family member who needs methadone for their opioid use disorder, has a severe pain condition that, is a small fraction of folks who warrant chronic opioids, because I think some people do. And I think, there's ways to figure out how to get that done. And sometimes there's not, okay, I'm not saying that there might not be ways to, but I think there's things to explore about ways to make it happen safely.
Yeah, and we should recognize in the context of this case that people with opioid use disorder, I think all of us will agree, have an enormously difficult time getting their pain managed in hospital settings. Okay, so I don't want anyone to think that I'm suggesting that shouldn't have been managed that way. It should, but if they're in the hospital for 5 months, I think there's an opportunity to transition that care in a way that will help this patient transition to the outpatient setting in a non-destabilizing way. All right. Anything else from the panel on this comments?
Yeah, I mean, I just want to point out, like, I feel like that must have been so hard for the patient to tolerate this 5-month hospital stay. Like with everything he's going through, his withdrawal, his severe pain, all of these procedures. So, I mean, I think acknowledging that all the hospital teams that must have been following him somehow made him comfortable enough to stay there for 5 months and receive treatment. So, it might have been, maybe he was on much higher doses of, IV Dilaudid for most of his hospital stay. And it was really, a Herculean effort just to taper him down to the MS-1 and oxycodone. So I think it is important to just, take each case as the individual case and just really appreciate each individual's specific factors and what they're going through.
Todd, can I just ask a clarifying question? He shows up at the first hospital that should have known he was on methadone because they had him for 5 months. I get that. Second hospital, though, I just want to be clear. The central registry in which every OTP in Massachusetts participates in is not available to hospitals or emergency rooms. Right? Okay. Am I turning around and I'm just community-based OTPs at this point, okay? The point being that hopefully will change. And I want to be clear, it is not on the PMP, and nor do I think is it headed to the PMP in Massachusetts. Is that true? Okay, so I just want to be clear, the normal place an ER might check to see if somebody's on methadone, they do not have access to. So that second hospital, why would they know? How would they know? It's a real failure in our system.
I'm not putting it here to place blame on the hospital. I'm putting it here to highlight the restrictions of the system problems that are causing this patient major problems. Okay, great. Thank you, Ruth. Ooh, I think I lost. Oh, there we go. Okay, I think this is the last case. So this is a hospital readmit back to the OTP case. 55-year-old with alcohol use disorder, opioid use disorder, seizure disorder, was on methadone maintenance, 76 milligrams. He was AWOL for 19 days from the OTP. He presented to the hospital with a seizure, was intubated in the field, had an alcohol level of 351. He was managed in the ICU setting, came out of the ICU, I think on hospital day 2. On hospital day 3 and 4, methadone was reinitiated at 40 milligrams. Hospital day 5, which is the day of discharge, methadone 85 milligrams was given with a plan to discharge to the OTP, where he presented back on day 2 and had some sedation at the window with a positive breathalyzer, and his dose was held. So I'm going to pause and let the panel dissect this case for me.
You just go back one slide.
Sure.
And I think one of the things that just sort of for this first part of the case that got me was, somebody who's on 76 milligrams of methadone who comes in for alcohol withdrawal, and then doesn't get any methadone for a couple of days. And I'm guessing either it wasn't thought about, or they were worried about over sedation. And it's hard to know how they look clinically, but I always think that if we should take the opioid withdrawal out of the picture, and then we have a clearer picture of what we're looking at with their alcohol withdrawal. So I would be thinking about definitely trying to get them their methadone sooner, unless they were crazily sedated from whatever we were giving them for alcohol withdrawal. So I'm a big fan of trying to get people's opioids back into them, both so they feel better, but also when you have this sort of mixed picture, it's a little unclear what to do. And sometimes what I've seen happen often is when people don't get their methadone here, they get way over treated with benzodiazepines because they're treating what they think is alcohol withdrawal, and it's really opioid withdrawal.
It's well said. This patient was intubated, so he couldn't get at least liquid methadone. I believe he did get IV fentanyl actually while he was intubated, but just based on my memory. But good points. Does anyone on the panel want to comment about missing 19 days, or the way that the titration went, having missed 19 days and then 40, 40, 85?
I was being good.
You got
I actually think it's tough to comment on that, not knowing what the patient looked like. I mean, I think one of the things you wanted to get at with this case is that, that next day, after only being on that dose one time, he's probably not sedated because of that big jump, right? So we still don't know whether or not that was an appropriate jump based on his clinical presentation, right? And so, there's a lot of sort of non-evidence-based things that happen in OTPs, again, part of the culture. And this highlights a couple of things. It's like what to do when patients miss doses. Ruth alluded to this. Every place has a different protocol. And again, I've been doing this 20 years. It used to be a time when OTPs in this region would cut people's dose 50% if they missed 2 days in a row. Our protocols have evolved. We do make dose changes, but 10%, not 50%. And, much quicker to get people back up to their dose, but that's not evidence-based. That's OTP culture right there. Another great point to debate, and I love that this has come up in our own system. It's standard that if someone blows positive at a breathalyzer at the window, that they don't get medicated, right? That it's a presumed, right? Does anybody have a system in their OTP where if someone blows positive on a breathalyzer, they still get medicated? No one, right? Let's look into that. Because my policy is people are always safer with us than without us. How can we determine truly if they're unsafe because of alcohol use? There's a lot of work to be done. At our MDT discussions all the time. This person's had 3 positive breathalyzers. What do we do? Well, for God's sake, keep them in treatment. Don't cut them off, because that used to be what happened, right? They get discharged because they're not safe to treat, right? And the opposite is true. So we got some real work to do on that part of OTP culture, I think, too.
Yeah, that's a good point. Marcy, if the case were, instead of going to the hospital, had been to your ATS unit, talk us through kind of what that would look like with the alcohol piece and the missing 19 days of methadone.
So if they came, obviously he wouldn't have been intubated. So
I got a vent on the way to your ATS.
differences. But they would have been, the patient would have been signed on to both protocols for alcohol use disorder and opiate use disorder, and kind of treated side by side for both of those conditions at once based on nursing assessment and the CU and the COW scales. I've seen exactly what Ari said, is that you gotta kind of figure out through good assessment, which withdrawal is kind of driving the bus, so to speak. So always you're gonna treat alcohol use first because it's fatal. And so once you kind of get those symptoms under control, to really look closer at what the opiate withdrawal symptoms are that the patient's having and medicate appropriately. Side by side, I do think that the 85 and then discharge on day 5. Like, if this was our ATS, a lot of situations that went on with this case would hopefully look a lot different. Like, for one, they would hopefully be stepped down to a lower level of care within our continuum so that we could manage them and follow them closely, because this person presents as extremely high risk for return to use on both alcohol and opiates. And given that they drank to the point where they needed to be intubated on the scene is concerning. And I think that's like, and then to not have any real observation time after you get to the 85, like, oh, here's, goodbye, good luck. And then they show up to the OTP, and what was the handoff, right, to the OTP? Like, I don't think that happens enough. We have the benefit of having one internal, right, and connected to our ATS. And so that's a like massive luxury. But when we send them blindly out to other OTPs, I have to say, us ourselves don't communicate to the level which I think that is needed, necessary to say what their ATS state has looked like, the medications they received, the difficulties they had with their withdrawal process, and to support their presentation next day at the window at an OTP clinic that's not connected to us. Because what would happen if they presented to a BHN clinic under the influences, we would try to get them back and connected to care as fast as possible, inpatient, as they've demonstrated that they might not have been ready to be out.
Yeah, I'll second that. From ATS, I think we can do like a much better job with the transitions to OTP. I think we get very minimal information. It's, really coming from the aftercare planners who are not medical, just mostly sending like this biopsychosocial, and there's not a lot of medical pass off. And especially, I just feel like we're seeing more and more medically complex patients and increasing methadone faster than we were before. So I think there's definitely room for improvement there, and just having more thorough pass offs to OTPs and other treatment sites.
Great, thank you. So from my perspective, a take home from all of these cases and the prior panel is the importance of communication and networking and knowing each other and trusting each other and knowing when and what needs to be communicated is paramount to helping improve care for these complicated patients. I think there's opportunities hopefully in the future for electronic communications to occur quickly, which would eliminate some of these situations that have been highlighted in these cases. And maybe I'm overstating it, but I think that the importance of today and bringing people through MASAM into the room who work with each other and who are experts in the field, I want to underscore the importance of that because that is one of the missions of MASAM. So thank you for being here. I'll open it up to questions for the panel.
Hi, I'm Matt Rogalski. So I direct OTPs. We used to be Habit Opco, but now we get called CTC in Fall River and East Wareham. I guess really my question kind of generates from what we were just talking about, is that oftentimes because of how understaffed we are on both sides of the coin, I'll get a last dose letter, and it can be really hard to get in touch with somebody at the ATS to figure out exactly what you're saying of what kind of a titration protocol or a dose change protocol you may have had for somebody coming in. Brainstorm ideas for different ways that we can put communication in place to give me some more context so that I can be more confident that when I'm giving them that dose that's increased coming back, if it's more than 10, 20 milligrams, that I'm like, okay, they've assessed them really the way that I would have think that they would have with that close care, and that I'm cool to just keep going.
Yeah, I mean, I think staffing is a huge issue. So I think, I've been trying to advocate just for more funding, more resources to be dedicated to our programs, because I think just with our our current staffing, just, minimal nurses. We only have one provider really per day for all of our ATS and CSS programs. So there's just really limited bandwidth to do more like direct outreach. I would love to, have providers for more complicated cases, be able to call and give a warm handoff. I think just because we don't have an electronic medical record system right now, that makes, just creating a discharge summary and sending a discharge summary really challenging. I think we're signing a contract this week, so hopefully within the next 6 months, we'll finally have one. But I think once we get that too, it's going to enable us to really like electronically send these discharge summaries to OTPs just to give a little bit more information. We've also been trying to just work on our communication because I think, not only OTPs, but just emergency rooms and hospitals have a really hard time reaching us. And a lot of times we just see in the notes, like tried to reach DIMIC, unable to reach, left voicemail, and then the patient sort of like sent back to us. So we've really been trying to think through how we can just improve our communication pathways and just like assigning cell phones, like for each, the behavioral health specialist and the nurses and the provider each shift, so that there's like always a clear number for people to contact, because our phone tree can be very confusing and people just get lost in different voicemail boxes. So yeah, we're definitely actively working to improve it.
I just want to say quickly to that question also that I think, as was stated earlier, about kind of trusting that the patients have been stepped up to a higher level of care, and that the ATS is most often is going to do what's in the patient's best interest regarding their methadone dose, and kind of being willing to accept that dose when they return back. And then even if we're not able to do the handoffs like we would like to do, I think that's an important point to take away.
Yeah, I agree with that. That's an important point. It's not dissimilar to when people leave the hospital with a medical problem. So I think that analogy is important. You want to say something, right?
Yeah, actually, one of the takeaways from our call with the local OTPs, I think it was actually Katie Krauskopf's idea from Mira Vista, was, and we haven't implemented this yet, but I think it's doable, is that just updating our last dose letter sheet to actually be a dosing history and check boxes for where they admitted for benzos and for alcohol. It'll also involve us updating our release of information and what people signed for. But I think in the interest of safety and being able to do this best, if we can update what our last dose letter is for dosing history, benzos, alcohol, and that was sort of from an OTP perspective, they were like, that would be wonderful. So I think that's doable, and that's like the next thing to do on Monday.
My name is Steve Jones. I'm still from Western Mass. And you guys have talked about the ATS, the OTP, and whether somebody gets a phone call or whether the phone calls are missed, and whether somebody's going to be approved for methadone or not. And Todd, you talk about communication, and it's really important because the stakes are very high. In the midst of fentanyl, some of those people that the phone call didn't happen are going to die. And I think we have to think about, why the hell do we have all these complicated rules that are killing people?
Hi, I'm Liz Quinn. I work at Lynn Community Health Center. I'm a primary care doctor, so I'm just trying to learn methadone. And I run our Moms Do Care program for pregnant and parenting women with substance use disorder. So that's really why I want to learn methadone. What struck me in these cases is that so many of them, it seemed like, yes, communication, but also a couple more days in the hospital. Like quite a few of the cases we talked about today had that. And because I work with pregnant women, I have the luxury that the withdrawal is in and of itself an admitting diagnosis. So I can push and say, no, I want this person to stay for however long. But for those of you working for medical patients, are you able to do that push to get the actual the methadone dosing right? Like someone's already admitted for their medical problem, but it really, in multiple of these cases, it really seemed incredibly detrimental to discharge them when they were discharged. And I know right now hospitals are like the fall of Rome, so it's like really hard to have extra hospital days, but I'm just curious if anyone has tried that out and how that has gone.
I think it's really hospital specific and sometimes like census specific. And I think, at least my experience, I mean, I work in a relatively small hospital, was like where I know everybody. is I can make that call sometimes, like once in a while, so when it's like, I can make that call once in a while. And sometimes people are still like naive about methadone, so you can sort of just speak really fast about methadone. They're like, they disagree. They disagree. But I was actually thinking about it as a great example with the pregnant patient. I think, and I think there's something actually too, maybe like if you have that conversation, I called the OTP director and said they're not comfortable, but this person's, at risk of death. And like, you could I think that might be a way to sort of build in the advocacy is like, look, I think this person needs this dose. If they walk out and they're not on, I'm afraid they're going to over, so I think I thought about that same pregnancy case and I was like, maybe if you speak to the OTP director and they say no, you might have a little bit, it's, making a case.
Justification.
Yeah. But I'm curious, it's probably very different in different hospitals. So that's just been my experience.
Yeah, it's a great question and it's complicated. I'm going to try to answer your question with a brief patient we have right now in the hospital. She came from CSS to the hospital with a medical problem. She spent now 6 days in the hospital. She's medically cleared to go back to the CSS. The CSS has no beds. She's from the western part of the state. She's now in Weymouth. She's unhoused. What is the hospital supposed to do with these cases? I know the answer to that. We're going to advocate for her to stay in the hospital until the CSS has a bed. This is why networking is important. Can we talk after? It's just, I mean, I want to sound optimistic, but these cases they're nightmares for the patient.
Yeah, I think when I was at MGH, it was very variable, like sort of like provider team variable. Like I think especially usually like the surgical teams are a little bit like faster on average, just wanting to get the patient out. But sometimes you could really advocate for the patient depending on who their attending was and who their residents were. It would really determine how long they were willing to get them to stay there, wait for a bed to open up, or just have a few more days for their methadone dose to reach a steady state.
We'll take, you have a question too? Last two questions. Go ahead.
I'm still Natalie Saul from Lawrence, Greater Lawrence. I want to ask about the dose confirmation. I've had terrible situations where, someone was under a section and didn't get dose confirmed and had terrible experiences in ED. My understanding, this is maybe a BSAS policy question, but my understanding was that it was an obligation to have after hours numbers. And my impression is that like the success at making sure hospitals know that or having them actually reach people, like we don't use them enough. I don't know what the problem is, but so that's my first part of the question. And the other part, is there anything, a lot of this might have to do with 42 CFR. Are there any statewide mechanisms by which we can improve like the anxiety or communication challenges around those confirmations? Because it seems like a lot of it has to do with, there's not assigned, like the hospital says, I need a release, even though in reality, like the methadone clinic probably has a release on their end and we don't need a release to ask. So I think that how can we make that better? So if we don't have success with after hours numbers, do we call you guys? Yeah. We call, okay, so. Okay.
So you asked a great question from my perspective, because you hit my sciatic nerve. One of my key frustrations is at the hospital, we call the OTP and say, I have your patient. The patient's told us their dose. I just need you to confirm it for me. And they say, send me a release. And my response is, this is crazy. I'm not asking for information. I know this patient's dose. It's my patient. Why do I need to fax a release to you? and maybe I'm offline here, but I think it's a major, major problem. And it leads to bad patient outcomes because people leave the ED because they're not getting their methadone in a timely fashion. Thank you for asking the question. Last question.
He can't see those 5 minutes.
She'll cut me off. Yeah.
Thank you for taking my question. Dr. Sanchez here. I have never worked in a prison setting. And I have worked with a lot of pregnant women with opioid use disorders throughout the years. And one of the questions that I have or that I want to understand, and again, I've been going in and out, so I apologize if you've touched on that already, is in a prison setting, can women get split methadone dose? And in a prison setting, can women, if they choose to, transition from methadone to bupe or be prescribed bupe for opioid use disorders in that setting?
I'm going to let Dr. Baxter take that if that's okay.
Yeah, so we've not been able to accomplish split dosing for pregnant women. There are all kinds of logistical challenges. You should come visit, see what we go through to get the medication to the patients in the correctional settings. So we still do once a day dosing and haven't been able to come up with a system for splits. And I'll be interested in your experience because I know I remember you said that you can do that at Franklin. So I want to learn from you.
Yes,
the other
I'd be
question was
curious to hear.
switching
Yes.
is a challenge, but we do it. I mean, we're fortunate in our contracts with DOC, we provide all three medications, but sometimes you have settings where you have an outside contracted provider bringing in the methadone, and then you have another provider on site doing the buprenorphine. You see what I'm saying? And so then you have basically a transfer of care from one to another. So at Middlesex County, for example, we do this. It's all men there. We're not doing it for pregnant women. We do those switches, but you face those logistical challenges as well. But we're trying to push to the point where as long as there's not a safety concern or a diversion problem, that patients can achieve medication of choice, even in a correctional setting, right? Imagine how innovative that is, so that they're on the medication of choice at the time of release.
And thank you, Dr. Pote. How do you guys do
It's
it?
good to see you. There's, I think 5, now I'm going to again look at Jen, county jails that are their full OTP license now in Massachusetts, maybe 4, maybe 5. We have a lot of control. When we're our own methadone clinic. We can do whatever the hell we want. And so that's what we do. We split dose pregnant women. If they need it, they get split dose, period. But we don't contract out with somebody else. It's hard. The carceral system is, as you can imagine, it's like super challenging to do the work there. And we will transition people between bupe and methadone and naltrexone if that's what they want, back and forth. We don't normally do that during pregnancy, but.
Thank you to the panelists. We'll give them a
Thank
round of
you.
applause.
Okay, guys, I know that people are getting tired.